Hi everybody, welcome to the latest session of Navigating the Medical System. Tonight is February 10th. February is National Heart Month. We will learn how to take care of our hearts this time. And we have two major problems that we're going to talk about tonight. One of them is arrhythmias, which we are a little familiar with at this point around here. And the other one is coronary heart disease, and unfortunately everybody's familiar with that. First speaker I'm going to introduce is Dr. Gregory Pantone, who's a cardiologist at New York Hospital Queens. You can look in your programs if you have one and look at his biography. I can tell you right now he's a terrific cardiologist. He's going to give a great presentation, and he's going to talk about coronary heart disease. Greg?
The clip is on the chair.
Good evening, everyone. Today,
Step back a little bit. Just think selfie and you're fine.
okay, tonight I'm going to talk to you guys a little bit about coronary heart disease and what that means. What are some of the signs and symptoms that you should be aware of, that you should bring to your doctor to discuss? What are some of the things that we can do to treat coronary heart disease, and some of the options that are available. Okay. Just a little bit about myself. I joined the cardiac team at New York Hospital Queens about a year ago. I completed my internal medicine training at New York Hospital at Cornell and did my fellowship at North Shore. Some of the areas that I'm interested in involved non-invasive cardiac imaging, imaging of the heart that includes echocardiography, nuclear stress testing, and lipid metabolism. So coronary artery disease is obviously a major health problem. It's one of the leading causes of mortality in the United States in men and women of every major ethnic group. It claims more lives each year than the next four leading causes of death combined. And every year, approximately more than 700,000 Americans suffer their first heart attack. This obviously leads to heavy cost burden on the healthcare system. And 2010, coronary artery disease alone cost the U.S. greater than $100 billion in services, medications, and lost productivity. Coronary artery disease actually is more common in men than women, and it seems that women, especially in the premenopausal state, suffer much less in the way of having a heart attack than men. In postmenopause, they seem to catch up a bit, but still, throughout lifetime, CAD is definitely more prevalent in men. What is coronary artery disease, and how does it surface? Basically, we think of it as a buildup of plaque in the artery walls. This plaque is made up of lipid-rich material, and that's why your doctors have been interested in checking your cholesterol numbers. We learned that the higher the cholesterol is, probably the more prone patients are to developing plaque. There is probably also genetic factors that play a role. This plaque inside the lumen of the artery, if you think about it as a pipe, starts to clog the flow of the pipe, which is the blood flow. And over time, that can lead to symptoms, which we're going to talk about. And there are times where it can cause acute occlusion of the artery, which can cause a heart attack. And we have also been interested in recent years in discussing issues of inflammation in the artery wall. That is probably a process that's multifactorial, that just doesn't have to do with cholesterol alone, but that there are probably toxic inflammatory markers that cause buildup of plaque in the artery wall. And this is important because aside from checking cholesterol numbers, doctors have become more and more interested in checking some of these inflammatory markers. So this is a little schematic of what progression of coronary artery disease can look like. This is a pathologic specimen of the lumen of an artery, of a coronary artery. And you can see that the lining of the artery is starting to build up some plaque. This is very mild. As plaque progresses, there becomes this very lipid-rich, encapsulated plaque that starts to encroach on the lumen opening. So you can see there's a major difference here. A person that has an artery that looks like this may develop symptoms of chest pain when they're trying to exert themselves, because if you have an artery like this, that when your heart is exerting itself, it needs more oxygen, it needs more blood flow. There's obviously a limiting step here where it's not getting the blood flow that it needs. When people present with a heart attack with acute chest pain to the hospital, most often the artery lumen is completely closed. And that's likely to do with platelets that stick together, and occasionally this plaque ruptures, causing an inflammatory response, and platelets that stick together, causing complete occlusion of the artery. So who is at risk for coronary artery disease? We kind of already know about some of the common risk factors, but smoking, high blood pressure, diabetes is certainly one of the leading causes of coronary artery disease in the U.S., and diet. So Western diet, fried foods, foods high in fat, we know can lead to plaque buildup in the arteries. So some of the things that I just mentioned, along with obesity, sedentary lifestyle, and the other important one is family history. So the entire process of coronary artery disease and plaque buildup is multifactorial. It's a combination of these factors, and certainly genetics play a role, which is why family history becomes important. So what can we do to prevent coronary artery disease? Well, there are several things that we can do in terms of lifestyle. Exercising, we know, helps. And recommendations for moderate exercise, 30 minutes a day, 4 to 5 times a week. As I mentioned before, eating a healthy diet, low in trans fats, high in omega-3 fatty acids, and a diet that consists of protein, fruits, and vegetables. Smoking cessation, controlling sugars. Very important to keep up to date with your screening visits with your primary care doctor, getting your cholesterol levels checked, your sugars checked, and your blood pressure. Your primary doctor might also get an EKG, which may look for any kind of injury pattern that might have already occurred to the heart. Aspirin is, has definitely been shown to protect people from developing, not developing coronary artery disease, but preventing heart attack and stroke. However, it is not for everyone. And that's something that you need to talk to your doctor whether you should be on aspirin or not. Aspirin's not a completely benign drug and has been associated with increased bleeding risk. So we feel that patients who need to be on aspirin, the risk of bleeding is certainly less than their risk of developing a heart attack. So this should be talked in detail with your doctor about if you're on aspirin, whether you should stay on aspirin, and if you're not on aspirin, whether you should be on aspirin. So a lot of you have gotten back cholesterol results from your doctor, and sometimes difficult to interpret, but cholesterol is broken down into different types. There's good cholesterol, which we know helps protect people against having a heart attack, and that is called HDL. So what we know is that the higher the density of the cholesterol particle, the more protective it is against having a heart attack. So high density is good cholesterol. On the other hand, low density or otherwise known as bad cholesterol, we know promotes lipid buildup and plaque buildup in the artery. So when you get your cholesterol results, it's very important for you to look at this breakdown, look at your LDL, and look at your HDL, and talk to your doctor about what these different things mean and where the cutoffs are. The other thing is, as I mentioned previously, cardiology has sort of expanded beyond just cholesterol levels. And we're starting now to look at inflammatory markers, very low density particles that we have not looked at before, to assess whether a patient is at significant risk. To see if a patient is at significant risk. Some of these inflammatory markers, which I had a discussion earlier with some people in the audience about, are CRP, which is an inflammatory marker, and another particle that we call lipoprotein. So these are something that you can also discuss with. The other lipid particle that is typically checked is triglyceride level. This slide is just showing a brief overview of a slide of showing several studies that have been done looking at statins, which I'm sure most of you in this room have heard of. The most famous is Lipitor, and the other names are Zocor or Crestor. These are drugs that help lower cholesterol, and they also help prevent heart attack. And this slide shows that patients that were on these statins had a major reduction in coronary heart disease risk. And these studies have been going on for years and basically show again and again the importance of statin therapy and its protection against heart disease and heart attack. So how would you know if you had coronary artery disease? What are some of the signs and symptoms that you may exhibit? People with coronary artery disease actually might feel well at rest, because the slide I showed you before where the lumen is actually getting smaller and smaller, they still may be getting good blood flow during rest when their heart is resting and it doesn't need additional oxygen. But classic for coronary artery disease is that when that same person tries to go up a flight of stairs or they walk a block, they may feel short of breath and they may get chest pain. And those symptoms will go away once again when they rest. So when the heart is put to the task, there's not enough blood flow there, and that can cause the pain. So some of that pain may be classic chest pain. It might be in the form of shortness of breath. For some people, they may just feel more tired. They may get palpitations. And even passing out can be a symptom of having coronary artery disease. I like this slide because it really gets to the bottom point the bottom issue for 2 points. One is, not everybody who presents with coronary artery disease presents typically, meaning not everybody has classic chest pain. Not everybody is going to present by the book, per se. This is especially true in women. So we know that women, unlike men, usually present, or more often present, with symptoms that aren't quote-unquote classic. And that's why doctors have to be more aware of the symptoms that women present with, and it's one of the reasons why there's been a very big Go Red movement in the month of February for women, to make both patients and doctors aware of the importance of this. This slide shows a woman who is grabbing her right shoulder. And we normally think of the presentation of coronary artery disease as left-sided. Left-sided chest pain, radiation to the left neck, left arm, is usually the typical presentation. But, as you see in the slide, it can be other presentations as well, especially, like I said, in women. So how can you go about getting this diagnosis? What is important? What do you need to talk to with your doctor about? The number one and probably the most important thing is a history. So you need to tell your doctor a good history. What do you feel when you're walking? What exactly, is a symptom? Is it chest pain? Is it shortness of breath? Does the pain radiate? Does it get better with rest? So all of these are important questions. Is there a family history? A lot of times when I see my patients, it's a very important factor, and we know that there's a big genetic component to coronary artery disease. So genetic family history is extremely important. Your doctor might discover on physical exam something that might alert him or her to a problem. That could range from anything where they might hear a murmur. They may actually hear something in the artery, which could represent plaque. Or they can sometimes people get lipid or cholesterol deposits near the eyelid that can be a marker for high cholesterol levels. And certainly, if someone's having chest pain, the examination becomes important in terms of ruling out other causes of chest pain. So we like to think of the cardiovascular system as the entire cardiovascular tree. That is, the arteries that supply your heart belong to the same tree of the arteries that supply the brain, the legs. And so manifestations of heart disease may actually take the form of manifestations of plaque in arteries that supply other organs. For instance, patients may feel pain in their legs when they walk. That could be a sign of peripheral vascular disease, which is the same process that's occurring in the legs. Somebody who has vascular disease peripherally would certainly be at risk to also have coronary artery disease. Along those same lines, doctors frequently check the carotid arteries. Again, those are all part of the same vascular tree. There's something that doctors can look at with an ultrasound. So significant plaque buildup in the carotid arteries may also indicate that there's a problem in the coronary vessels. Your doctor could do an EKG. Now, sometimes EKGs can be normal, especially if a patient's resting, and they could still have a problem. So a normal EKG doesn't necessarily rule out having coronary artery disease. But this patient doesn't have a normal EKG. So there can be changes that can alert your doctor to do further testing. What other testing can be offered? For patients that are having symptoms, or even sometimes as a screening for a patient that has high risk, we can do a stress test. Stress tests come in a couple different varieties, but the basic stress test is putting a patient on a treadmill, watching them walk, following their EKG, and then doing some sort of imaging of the heart. By doing this, we can tell if patients are having symptoms when they're walking, and we can tell if their EKG changes that might alert us. This is a patient who's getting in the middle of having a stress test. You can see that he's connected here with the leads. The doctor is following the EKG. The technician is taking the blood pressure, and these are all the things that we do and monitor during a stress test. Echocardiogram. This is another way for cardiologists to image the heart. This is an ultrasound of the heart, and this gives us information as to heart function. If somebody's had a heart attack or if they've had injury to the heart before, we would be able to tell us information with this test. The other valuable information, sometimes your doctor might tell you have a murmur, which can indicate a leaky valve, and this is a test that we would look to figure that out. I put this slide up. This is, some of you may have had this test. It's a nuclear stress test. Otherwise, some people refer to it as a stress thallium. This is a stress test which involves either walking on the treadmill, or it can be done chemically for people who can't walk, and then going underneath a camera that looks like a CAT scanner to image the heart. So you can see that all of these are images of the heart sliced in different directions, and this can give us information as to the blood flow of the heart, to the heart. One of the newer technologies in cardiology has been to try to image the arteries that supply the heart without doing an invasive procedure. And what we have today is something called a cardiac CAT scan, in which we can inject dye into the forearm IV and light up the coronary arteries. And we can determine if there's plaque in those arteries. This is not yet standard of care for everyone, but it's something you can certainly talk to your doctor about. The sort of gold standard to look at the arteries that supply, to directly visualize the arteries that supply the heart, is something called a coronary angiogram. This is an invasive procedure. It's done in the hospital setting, and it involves putting a catheter either through the artery in the wrist or in the leg, and looking at the arteries directly on a screen. This is an example of a cardiac cath lab where the patients are taken into a OR type setting, and this is where the procedure is done. It's also called a cardiac catheterization. Now, if someone did have a blockage, this would be the procedure to do to open that blockage with either an angioplasty or a stent. So this is what doctors would see when they actually shoot dye into the arteries during catheterization. This here, what you're looking at is 2 out of the 3 major arteries that supply the heart. And these are both on the left side. So this patient happens to have normal arteries. So what are the medicines that we talked about in terms of managing somebody that we already know has blockages? And some of those medicines have to do with thinning out the blood. So we talked about aspirin before, but there are other blood thinners which are called Plavix, and other types of medicines that can help either with blood pressure or with reducing the workload that the heart has to do. Some of you might have heard of nitroglycerin, which is something that patients can take if they have blockages and they get chest pain. Nitroglycerin is usually given under the tongue, and that can sometimes alleviate the chest pain by dilating the artery. If medicines are not working, then we need to consider actually fixing the artery. And whether we do that, with the procedure that we just talked about, where we can open it up with an angioplasty or a stent, is an option. The other thing is, a lot of patients will come into the ER with an acute heart attack. And again, as I mentioned before, that means that their vessel is completely occluded. And it's likely that platelets have stuck together. So it's very important for doctors to open up that blockage as soon as possible to save the heart from damage. So this is a picture of what a stent looks like. Pretty small device that gets inserted at the tip of a catheter. And again, either through the wrist or through the leg, that catheter gets inserted up into the heart vessels and is placed in the middle of the blockage. So you can see here that this is lipid-rich cholesterol plaque. This patient might have an 80 or 90% blockage. The stent catheter goes in between. A balloon is blown up, and the plaque is pushed up against the wall, and a new lumen, a new artery lumen, is created with a stent. So on the pictures on the right, I don't know if you can see from the back, but this artery here is completely blocked. This is a patient that presented to the emergency room with an acute heart attack. They're taken immediately to the cath lab, catheter is put in, the vessel is opened, and blood flow is restored. The other option for people with coronary artery disease, especially in people that have multiple vessels involved, is a surgical option. And this is something that we commonly refer to as bypass surgery. So bypass surgery is a surgical procedure. It's done by a cardiothoracic surgeon. And what they do is they create new arteries by using the veins in the leg or the artery that runs down the chest wall, depending on how many bypasses a patient needs. This is just a diagram of what an open heart surgery would look like. So that's my presentation for today, and I guess we'll do questions at the end.